I'm singing your praises. I can't. I'm so
I didn't
impressed.
create that.
Oh, I thought you did. No, you did this.
It's what it is for, but this is what the percentage is.
The percentage right now in the bill is 10%. So what are you paying? What's your percent of payroll run?
It goes
What
into
you're
that.
paying premium? It's the cost to the employer, whether that be
Right now, I'm not because people are much as
you're not enrolled. Yeah, I just saw it on the calendar. Francis mentioned it. They're doing so many, they can give everybody a directive to come to. She's one of the years, Francis. Somebody's on a bus with them, pay for all.
That other TV being on really tied them together.
So this is, okay, I was going to do
A lot of DSA people just like my classes. So Medicare for all, and I advocate taking
it's just
Yes, I want to go to Houston.
consider the candidates, the other candidates. What is it, what numbers is covered?
shallow.
There's cameras in the door, and then there's proof cameras. When you have them or
Well, that's sort of what it is.
So are you guys like official in the mass campaign?
I'm happy.
What do we want? Medicare for all. When do we want it? Now. What do we want?
Medicare for all.
When do we want it?
Now.
What do we want?
Medicare for all.
And when do we want it?
Now.
Hello. Good afternoon. So we're all here today because our movement for health justice in this country is growing. And on behalf of the Pioneer Valley DSA, welcome all of you to this growing movement for Medicare for All. My name is Frances Boyes. I am co-chair of the Health Justice Working Group for this chapter. I'm a union representative, and I am also a single-payer activist. So I have no free time. That's what that means. Our speakers today are going to engage us in discussion around what this moment, this political moment in time means for us at both the state and the federal level to advance our movement to win. And when I wanted to share some of my own personal experiences as a canvasser, an experienced canvasser for Medicare for All, Every time I'm out talking to people in our communities about healthcare as a human right and about a Medicare for All program, both in Massachusetts and for the United States, I am guaranteed that two things are going to come up. Who can guess what one of them is?
How do you pay for it?
How do you pay for it? Never fails. So what is the second thing that comes up?
We don't want the government running our health.
Well, sometimes. Yes. I'm not always guaranteed to get that though, because the other thing that I'm guaranteed to find when I'm talking to people about Medicare for All is that they are in support of it. It doesn't matter where they land on the political spectrum. It doesn't matter what their class interests may be necessarily, whether they consider themselves working class or middle class. People are suffering under our current healthcare system, and they want to see it fixed. And when they talk about being able to cover everybody in this country for less money than we cover only some of the people in this country, then it makes perfect sense to them. So today, hopefully for those of you who may be new to this movement, and also for those of you seasoned activists in the crowd that have been having these same conversations that I've been having, a lot of you for more decades than I've been having them, we're going to leave today with a better understanding of this moment in time politically and how we can engage people in our communities on those two things that always come up when you have a conversation about Medicare for All. So, not to delay, our first speaker, I'm really, really pleased to introduce Deborah Levinson. She is co-convener of Western Mass Medicare for All. She's also on the board of the statewide coalition here in Massachusetts called MassCare. And Western Mass Medicare for All had created this network of hubs throughout Western Mass, which led us to a victory in the last election on our ballot question. Over 70% of residents in Western Massachusetts are demanding that our state legislature pass laws to change our healthcare system to Medicare for All in Massachusetts. So using this model that Western Mass Medicare for All has adopted, we're now scaling up and taking that to the state level. And Deborah can talk to us about a little bit of the history and what that entails and what we can look forward to as this movement continues to grow in Massachusetts. So, Deborah.
Okay, so that's about half my speech here. So. Okay, thank you. So thanks to Pioneer Valley DSA for organizing this great event and for letting us talk a little bit about the state work too. So when pressed about Medicare for All at an event last year in the Berkshires, our U.S. Representative Richie Neal said that he supported it. But he thought the conversation should take place at the state level. Recently, the new co-chair of healthcare financing at the state level was quoted saying that she supports Medicare for All, but she thinks the conversation should take place at the national level. I think we need to make it clear that we will continue to talk about this at every level. In Massachusetts, we had a strong single-payer movement. It started 20 years ago, and we have people in this room who were part of it, led by Jobs with Justice and a broad labor coalition, including the Mass Nurses Association. When healthcare reform finally reached the top of the agenda here in the 2000s, the powers that be under Romney, including Blue Cross Blue Shield, the largest insurer in this state, kept single payer from even being considered. Eventually, they delivered Chapter 58, or what came to be called Romney Care, a reform model that maintained the private insurance industry and set the stage nationally for the Affordable Care Act. The passage of Romney Care in 2006 took the wind out of the sails for single payer. The campaign became narrowed. They adopted a state house-focused agenda, repeatedly submitting legislation that has never, to this day, gotten out of committee, despite a supermajority of Democrats in both houses. Then, in 2016, the national energy and excitement of Bernie's campaign also re-energized the state single-payer movement here, and we began to organize in Western Mass. Why even bother to organize in Massachusetts? Don't we already have the best healthcare in the country? Well, yes and no. First of all, by global standards, that's a pretty low bar. We do have several world-class hospitals in the Boston area, but Massachusetts is one of the most unequal states in the country, and our healthcare is among the most expensive. We brag that only 3% of our population are uninsured, but that still means that we have 200,000 people without any coverage at all. And in some sections of Springfield, for example, the uninsurance rate is twice as high or more. There are also an increasing number of people who are underinsured, unable to afford care even with coverage due to high deductibles and out-of-pocket payments. Meanwhile, costs continue to rise. The Partners Healthcare conglomerate in Boston is a pricing gorilla. Starting years ago, they negotiated higher reimbursements from Blue Cross Blue Shield in exchange for Partners demanding the same high rates from other insurers. This remains one of the drivers of soaring costs in Massachusetts. The issue is a hot one for our towns and school districts, where strong public unions have maintained decent benefits until now. On average in Massachusetts, municipalities spend 20% of payroll on healthcare benefits, while under the proposed single-payer system, they would pay 10% or less. But instead of single-payer, the state passed a law several years ago to allow towns and cities to undercut collective bargaining for health benefits. Two local towns, South Hadley and Belchertown, recently voted to implement that law. And on Wednesday of this week, some of us will be in East Hampton to try to prevent a similar vote in East Hampton. So what is our plan? In the past year and a half, as Francis said, we have been organizing aggressively in Western Mass. We have 8 active groups called hubs in Franklin, Hampshire, and Hampton counties, and reaching out into the Berkshires. The hubs have organized public education events. They have passed town and city resolutions in support of single payer, and they've lobbied local legislators. We implemented a highly effective visibility campaign throughout the primary season last year, including door-to-door canvassing here in Holyoke, organized by the DSA chapter. The legislative delegation from Western Mass is now much stronger on single payer than it has ever been before. We also ran, as Francis also mentioned, a non-binding ballot question in 6 legislative districts across this region. It passed actually by an overall vote of 77%. And perhaps even more interesting, it won in every town and city in which it appeared. No exception. Statewide, as mentioned, we helped to initiate, not mentioned yet, we helped to initiate a new Medicare for All caucus in the legislature, and we will be working with them. And we are also scaling up the model, as Francis said, so that the state coalition, called MassCare, will be building the grassroots movement with hubs in every state representative district across the state. So we're doing pretty well, and we're beginning to get some pushback. How do we respond? Number 1, we need to call out the phony studies. A bill was submitted this session in the Massachusetts legislature by Representative Hogan calling for a special commission to study the implementation of single payer. But it's a wolf in sheep's clothing, as it has been in other states. The commission is stacked with representatives of the insurance industry, including our old friend Blue Cross Blue Shield, and appointees of the governor, who was a single payer foe and a former healthcare executive himself. There are no representatives of healthcare providers or consumers, of working people, or single payer advocacy groups. Number two, we need to take on the so-called practical incrementalists. The Mass legislature and some health reform groups will focus on specific issues this session, such as the high cost of drugs. That's well and good and needed. But we need to call it what it is. It's triage for a failing system. It is not a substitute for ongoing work towards single payer. And finally, we need to resist the tendency to focus only on cost. There will be a push for another cost study in Massachusetts. And in my opinion, we do need to support that because the legislature will not budge without it. But we have to push for more than a study. We have got to begin taking cost savings as a given and move on with the work of building the broad social justice coalition for healthcare as a human right that we know we need to win. So thank you. If you didn't have a chance to pick up some of our materials on the way in, please get them as you leave. Please join us in Springfield on Saturday, March 23rd. We are having a speak out. The new Springfield Hub is organizing it, and it will be 2 to 4 in the afternoon at Springfield City Hall. So please come and hear what your neighbors have to say. If you're a Springfield area resident, please speak out. There will be support. So thanks very much.
Medicare for who? Medicare for all. I can't not yell in front of a room full of people. So it's my pleasure to introduce our featured speaker. He is on his tour of the Northeast, helping a lot of the DSA chapters continue their work of getting out into our communities to educate and do the outreach that is necessary to build this movement. Michael Leidy is a fellow at the Sanders Institute. He is formerly with National Nurses United and formerly the National Director of Democratic Socialists of America. So please welcome him to Holyoke.
Thank you very much. This is an extraordinary pleasure for me to be here. I was a very close friend and colleague of Tim Carpenter and had the pleasure of introducing Bernie Sanders when he spoke at Northampton in 2014 when we presented him with 10,000 petitions of Run, Bernie, Run. If you were there. And so I really believe that if Tim were here, he would be in the room, of course, and so I'm going to take the position that he is presented. We did a lot of work together when I was at NNU, and he and I, learned many lessons when we were doing this healthcare work. And one of the fundamental lessons we learned, really from that time that I learned specifically, were lessons about the human condition. That registered nurses have shown me through the profession and art of caregiving what a healthcare system actually could be if it were animated by those values and the work that registered nurses do at the bedside every day, or when they're on the streets demanding Medicare for all, or like in Massachusetts, like in Worcester and other places on strike for safe patient care, or like the initiative to establish limits on the number of patients nurses care for, which we won in California. Those efforts really show us that nurses will never give up on their patients or their country, and neither should we. That is a model for us. We all learned from the nurses' commitment to a single standard of safe therapeutic care, which, if you think about it, is really the enactment of equality at the bedside, because they take every patient as they find them. And that is an equitable standard that doesn't otherwise exist in the healthcare system, between the bronze plan and the silver plan, right? Between the platinum and your Cadillac plan. It's riven by disparity and inequality, and yet nurses enact, against hospital administration policy, a single standard of safe therapeutic care to the extent possible. And so when we talk about a Medicare for all system, we talk about a system that actually represents those values, those practices. And there's a fundamental lesson at the root of this that I learned, and that is that without justice, there is no health. And without health, there is no justice. And so we can literally see this rampant injustice. Look no farther than the misogyny of the present administration, the right's desire to control women's bodies. That's at the heart of the healthcare system. We know that women are more likely to use the healthcare system than men, either for themselves or as caregivers for their families. And also, of course, fundamentally, reproductive healthcare is at the root of human life, and yet it is diminished, and access to it is diminished under the present system. Women have longer life expectancy than men, and yet we know end-of-life issues are not taken care of. So health justice must mean very concretely repealing the Hyde Amendment, which for the first time the Medicare for All Act of 2019 does. No other single-payer bill, with the exception of Senator Sanders' bill last session, has done that. This is a new standard for us. It also must mean prohibiting discrimination on the basis of sex stereotyping, gender identity, sexual orientation. So those injustices are barriers to care in the present system. Direct relationship to health. We see many injustices in the structural racism that has manifested itself, the arrest, fines, and jail time done mainly by young men of color, black men specifically. We see the ongoing impacts of the exclusion from the workforce of East Asian and Pacific Islanders. Decades, generations excluded from the workforce. We see particularly the death, disappearance, and indifference to Puerto Rican Americans who have a huge presence in the Pioneer Valley. They were disappeared and killed in the aftermath of the hurricane in Puerto Rico, and the federal government didn't do anything. That was a public health crisis, directly as a result of the structural racism and injustice inherent in the colonial relationship between the United States and Puerto Rico. We see also that if you look at folks under 65, Native Alaskans, American Indians are more than twice as likely to be uninsured as Anglo-Americans. African Americans are much more uninsured than white folks. Latinx folks are actually some of the greatest supporters of universal health care because they come from countries that have universal health care systems. And they're hugely uninsured in this country, disproportionately so. We see, therefore, injustice at the border. The separation of immigrant or asylum-seeking families is a public health crisis. Imagine they're fleeing poverty and violence in their neighborhoods, the trauma and stress of that, its own mental health crisis. Then they're separated, thousands of kids. Apparently the Department of Homeland Security doesn't know where they are. The psychological toll, the physical impacts, the poor nutrition, the lack of health care in these facilities, this too is a full-blown public health crisis rooted in the injustice and xenophobia of the administration's immigration policy. And really, registered nurses know there's truly no border. The flu virus, it goes anywhere. We are literally, as Dr. King put it, caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. And can we see a different manifestation, a stronger manifestation of that than in healthcare and in relationship to these injustices? There is, therefore, health justice must mean covering everyone in the country regardless of immigration status. It must mean making sure that no one suffers barriers to care based on their race. That isn't true in the present system. So when we talk about Medicare for All, it's clear that all these social injustices both lead to and are reinforced by a basic injustice in healthcare. And through guaranteeing healthcare as a human right would not eradicate these. It certainly wouldn't rectify them, but it would, in a fundamental way, undercut the economic insecurity underlying them. And it's a powerful affirmative response. When we say guaranteed healthcare with no barriers to care, it's clear what we mean, those barriers. And it would greatly improve the material conditions of women and people of color and immigrants. We can talk about how do you pay for it. And a middle-class family making $62,000 a year will get a 9% raise through the financing that Peary study at UMass Amherst detailed. Working-class families save even more. It's extraordinary then that under a Medicare for All system, we will have the resources to address public health issues so that we take a holistic approach and that is accountable, publicly financed, like the public health programs we have today, and rooted in health justice. This system would not only enable us to address the social determinants of health, which are now, I was at a symposium with the CEO of the Boston Medical Center, and she's like, oh yes, we've discovered that the poorer folks that we provide care to don't have adequate housing, don't have adequate food, so we set up a food bank, and we set up a tenants' rights. And I said, oh, this is extraordinary. They recognize the social determinants of health, but they've decided to solve them one hospital system at a time. They're social. You can't. It's really something. And this is the corporate siloing of healthcare, and it also is that it's narrow because what causes homelessness? What causes poverty? Those are the social determinants of health that really determine life expectancy in many cases. But what's behind that? It's the political economic system that puts housing based on speculation, that creates a healthcare industry instead of a caregiving profession, right? That provides only minimum wage jobs, doesn't provide living wage jobs. So let's talk about the political economic system. When we talk about health justice, when we talk about Medicare for All in that context, then we can get at those systemic reasons for the social determinants of health. And so we are in this fight for health justice. But something that we have to get better at is understanding that on this path lies a confrontation with power. That this is a political fight that we're engaged in. And the ruling class, quite frankly, has a special distaste for universal health care. Now, why is that? I mean, they're willing to go along with, I guess, to some extent, until the present administration, environmental protection, other things, but maybe even raising wages or providing employer plans, right, that they can control. But guaranteed universal health care, no way. And when you think about it, it's not surprising, because other societies that have enacted these kinds of healthcare systems, national healthcare systems, have a much greater level of social solidarity, have a much more expansive view of the role of government, have a much greater sense of security. But what does the ruling class want? They want an insecure working class. They don't want a secure working class. They want one anxiety. Oh, I want to keep this job that I hate because I need my health care. They like that. They like that. That's not a criticism for them. And so what we have here is I don't hate to say it, I have to admit it, it's a class struggle, Francis.
There you go.
And it really is extraordinary because it's really kind of like 99 versus 1%. Who knew, right? But if you look at the public polling, 77% in Western Mass, absolutely. 70% overall, 85% among Democrats in some polls, 80%. 52% of Republicans in the Ipsos Reuters poll a couple months ago. 52% of Republicans who earned $30,000 or less in 2016 exit polls supported a federal guarantee of health care. That's the other reason they're afraid of this, because it destroys the class character of the existing political parties. Just like Deborah and Francis said, these are working class folks, regardless of party, who want this reform, because they know that health care is guaranteed for some, just not all. And when we have a system of political system as we do with the bicameral legislature, and we have, this House of Representatives close to the people, and then this august body of senators, you have to look to the Senate to some extent, because as we know in the ACA, they define what happened. And in the Senate, Ted Kennedy did not have a dozen senators for single payer in 2009. Bernie Sanders has 15. That is so far a high water mark for Medicare for All. So all this popularity and all this public support, I'm going to talk to a political science class on Tuesday, and I'm going to tell them this is a great example of the disconnect in American politics between popular opinion and elite opinion and who rules. Because it's like this is a fight within the Democratic Party. We don't expect Republican legislators necessarily to vote for this. They didn't vote for the ACA. But Republican voters, Republican supporters, independent who support Republicans, those folks are our constituency. And when we look at that, then you find that actually this isn't such a crazy idea after all. And they want to characterize it as crazy. So I want to talk about crazy for a second. You've all heard of United Health, right? Biggest insurance company in the country. Their CEO made $66 million last year. That's crazy. They made $12 billion in 2 years under the ACA. $12 billion. So I would say to the elected officials, I'd say the Democrats, okay, so 30 million Americans, 29 million don't have insurance. 41 are underinsured. 42% of Americans don't defer care, either a prescription or a doctor visit, some kind of treatment in I think it was 2017 or 2018, because they couldn't afford it. That's 42% of the insured. 41 million Americans underinsured because their deductible is more than $2,500. That's the standard definition. 78% of Americans are living paycheck to paycheck. And then Senator Stabenow says, oh, if your premium isn't more than 9.5% of your income, you're good. Hold it. I don't have any money left over in my paycheck to pay for anything, let alone 9.5% of my income. So that's crazy. And when you look at that, when you look at it that way, you understand that, really we have to congratulate Washington, D.C. because they've established bipartisanship. It is a bipartisan agreement between Senator Cronin and Nancy Pelosi that this is just too expensive. There's bipartisan agreement that 70% of Americans just don't understand. There's bipartisan agreement that the 1% who, Lily, you look at these numbers and you will find, because of how we finance healthcare now, that a wealthy person will get a tax subsidy for their healthcare that's provided by their employer, huge generous package of health benefits, not taxed, like wages would be, so that's a subsidy. Then that's a subsidy for the employer and for the wealthy individual. So when you actually add it up, as we did at the UMass Amherst Pew study, they found that actually the wealthy contribute a negative amount to healthcare. A negative amount to healthcare. And those same people, guess who owns stocks? In health insurance companies and pharmaceuticals, who gets dividends. The pharma companies are the most popular companies on Wall Street because their dividends are so high. The health insurance revenue, the hundreds of billions of dollars, are like a giant fund for the players on Wall Street. And that same class, as we know, are political donors. The same people who get the dividends and the stock benefits and don't pay anything for healthcare are the top 2.5% of the country, and they're the political donor class. So it is literally a circle where the better the healthcare industry does, the more money, obviously, for the wealthy, and the more money for the politicians. And so you're in that situation where you're almost like somebody's paycheck depends on not understanding this. Because you can't raise the money you raise if you decide to socialize 20% of the economy. And that's what's at stake here. Because there are only really two options to pay for healthcare. There are three in the sense that you can be on your own totally and just buy it yourself, and there are some countries where that's true. But generally, you're either going to have some kind of tax system that subsidizes a kind of private insurance, or you're going to pay providers directly from the government. It's basically that. Those are the choices at a fundamental level. And in this case, of course, there is a lot of misunderstanding about what that alternative might mean in other countries. And so the final tactic of the opponents is confusion and situation. Because we heard this week, Speaker Pelosi, oh my God, Medicare for all, $32 trillion. How do you pay for that? Well, in the same way that you would pay for $37 trillion because that's how much the present system would cost. Now, it costs $5 trillion more, so depending on how you count the first number, right? That's $400 billion more a year. So the question to Speaker Pelosi is, who's paying that? Who's paying that difference? And what we find, even though we hear a lot about the greatness of employer-sponsored plans, we find that in fact those plans are really just subsidized by the workers' wages. That you're locked in a job, you didn't get a raise, and all your money goes to the health insurance company, and then when the boss gets a higher cost plan, all those costs go to you too, and then your deductible goes up and your co-pays increase. I mean, come on, everyone has had this, right? Yeah. And this is what they say workers want to keep. I've had these conversations with the senators. Oh, but I was just talking to a state rep in Texas. Now, do you mean that people are going to have to give up their employer plans if they're happy with it? Oh, have you talked to a worker who's happy? I hadn't had that experience. But it is, it is this new talking point of confusion. Oh, you're going to lose your employer-sponsored plans. We can't afford it. This is a bipartisan message. John Cronin said it, and Speaker Pelosi said it. It's like the Republican Party were having a debate over abortion. This is a settled question among Democrats, and yet these folks say these things. So we say, oh, well, what political party in the world wouldn't pursue a program that 80% of its members support? That would be the Democrats. So here we are. It's clear the capitalists aren't just going to give us Medicare for all, and they're profiting wildly from this enormously unequal system. So we know this. Very, very clear. And what's really ironic, of course, is they've started a massive PR campaign with our own money, to convince us that we don't get it. And I love this. I just love that, because it's like, oh yeah, Americans don't know anything about Medicare, right? Oh no, never heard of it. Right? and so it's just too radical is the claim. So if it's so radical, why does every other industrialized country do it? Number one. And then how many times have we heard the Canadians, oh, the Canadians, they have to wait in line and the rationing and they don't really like it. I said, oh, really? So they don't like their healthcare system, so they're marching in the streets demanding Aetna. Oh, they're not! No, who knew? Why is that? Because they have created a sense of social solidarity and health and a guarantee of healthcare that no politician can challenge directly. And though they still have austerity, and though they have done other things badly to the material condition of working people in these countries, they haven't given up on their national healthcare systems because it does have that solidarity. So not only does the healthcare system come out of maybe a greater sense of social cohesion, but it also generates it. And that's what they're afraid of so profoundly in this country. Because if government just doesn't make wars and protect property, but actually guarantees people health care, my God, what else could it do? Right? Pretty soon it's going to convert the fossil fuel industry into a renewable energy sector that might save the planet. Can't have that. And it might actually create a housing that is for people, not for profit. And not based on speculation, but might be based on human need, because as Bernie said the other day, or yesterday in Brooklyn, we're going to build it with public funds. So all of a sudden you realize the door opens. There's an alternative vision of society. There's an ethos that can animate that society. Now, okay, so that all sounds good, but how do you pay for it? It's just too expensive, right? Well, check this out. So it's the Peary study, UMass Amherst Peary study, showed that we can actually keep healthcare down to 16%. Otherwise, it's going to 20% of GDP, gross domestic product. That's a huge difference. In 1980, we spent about the same as a percentage of GDP as other countries who have national healthcare systems. What happened since 1980? Every registered nurse could tell you. Elizabeth Rosenthal, one of the leading healthcare writers, said we became a healthcare industry instead of a caregiving profession. And she's no supporter of single payer. Angus Deaton, Nobel Prize winning economist in 2015, says that the healthcare system is the greatest example of crony capitalism, a driver of inequality. A driver of inequality. So when you look, and then we had that Koch brothers sponsored study that folks refer to, the Mercatus study, right? They said, oh, if you look at the offsets, we actually spend about 2 trillion less over 10 years than the present system. So that's the Koch brothers. That's their institute. We've won the policy argument. This is my point. There is not a policy argument against it. There is not actually a cost argument against it. Because why does healthcare in this country cost so much? Because prices are high. Okay, but it's true. Since studies since 2003 say we don't control prices, and every other healthcare system in the world does. So the costs are going up because of that. And so now they've just in the last couple of weeks, a study came out, 2/3 or 3/4 of the rise in healthcare costs are from price increases, because the insurers can charge whatever they want. The hospitals certainly charge whatever they want, and the pharma companies, of course, have no limits on their prices, and it all works for them. Because the more pharma charges, they can raise health insurance premiums. They get a percentage of profit. The more health insurance premiums go up, the hospitals can say, well, you got to give us a piece of that too. And then when the pharma companies raise their prices, the hospitals who have what they call charge masters, those are 200 to 300 times their actual cost. So they say, well, yeah, if I'm going to have to cover these expensive drugs, I got to raise my charges. And then the insurance companies, when they negotiate with hospitals, they don't start with, well, what's the cost of providing care to all your patients in a given year? No, they start with, what do you charge for care, not what you cost. And then we'll negotiate from there. So of course, the commercial insurers pay 150% more than Medicare, or 50% more than Medicare, pay 50% more than Medicare. And then the doctor spends 11 hours a week on administration trying to get reimbursed. And so here is then the question. It's not how can we afford it, it's how can we not afford it? How can we not afford it? So the other confusion comes from, they say, well, and Speaker Pelosi said this too, oh, well, you know, Medicare doesn't cover dental and vision. Right, that's why we improved it. Have you read the bill? Yeah. Because Medicare for All is very popular as a phrase. And so now what they have to delegitimize it. They have to say, oh, it doesn't mean that. It means this, or this means that. Right? So the latest thing is, oh, it's really not it's not a single payer system. Well, why isn't it a single payer system? Because they privatize huge chunks of Medicare. I argue that the folks who have the most to gain from improved Medicare for All are seniors who are currently on Medicare. Part B plans, that $135, don't have to pay it. The 20% copay under Part A goes away. The Part D drug plan replaced by negotiated prices and no donut hole. Why is it that commercial insurance is better on prescription drugs than Part D plans? Why is that? Because if you imagine, you have to design a health plan that makes money on people who need a lot of prescriptions. That's the premise of Part D is, how can we have private companies make money on these folks? Well, God, if you actually paid for everything, how can you do that? Better create a donut hole so they have to pay for a lot. And that's essentially their profits. Right? So seniors are essentially providing the profit margin of the pharmaceuticals. That's all gone. The new enrollees, majority of new enrollees in Medicare are going for Medicare Advantage. Medicare Advantage are HMOs. And for a little bit more money, you then do get dental vision coverage. But you also can't go to any provider. Sloan Kettering is not in any plan, any Medicare Advantage plan. I'm not sure what the equivalent in Boston might be, but I guarantee you there are hospitals in Boston that seniors on Medicare Advantage cannot go to. What we say is with improved Medicare for All, you get all that, and businesses pay substantially less, individuals get a raise, and all those things you give up choice for, because I told some elected officials, I said, you know, you guys have regulated behavior instead of prices. Because you've told us we can only go to these doctors. You told us we can only get these medicines. You told us these treatments are not covered. But you've never regulated prices. So why are you regulating us instead of the industry? And that's the trade-off. So you talk about these alternative systems. Have you heard, oh, we should go to the German model, the Swiss model. It'll solve these problems. So what you were talking about, the alternative, right? Well, does everyone know that the Swiss and German models, those are nonprofit insurance companies? They're essentially administrative entities that pay the same rates as each other, have the same basic benefit package, and have no profits, have no executive salaries. So I just want to hear the argument. I want to hear the argument about how you're going to say to United Health, hey, that 12 billion, sorry, that's gone. Stever, we can't make your 66 million. Oh well. And that's going to be easier than Medicare for all. Sounds like the same to me. So this is and then the other idea, this is all in the realm of confusion. The other idea is buying. Oh, let's just buy into Medicare. Yeah, well, the only problem with that, Senator Brown, is that if you buy into Medicare, how is it a social insurance program? Because the folks who are buying it are the ones who need it, and you're essentially relieving the commercial insurers of the most expensive patients. It is actually a way to shore up the private insurance system by relieving them of the most expensive patients through a buy-in. So you dump them on the public program, see how that goes. So I had this, it has been a while since I studied philosophy. But I thought that pragmatists meant that they were developing solutions to problems. So if you don't solve the problem, how can you be a pragmatist? Oh, I'm Senator Klobuchar, I'm Senator Brown, I'm from the Midwest, and so I have a practical solution that doesn't solve the problem. Congratulations. That took a lot of effort. So the bottom line is, yes, there is something called Approved Medicare for All, and it does have specific principles and elements behind it. So in the effort to undo this confusion, the Democratic Socialists have elucidated these principles. So, a single health program. Everybody in, nobody out. One insurance program that you're automatically enrolled in. Because how else do you get the economies of scale? How else do you go to the drug company and say, oh, you want 331 million customers? Deal with me. Well, I don't think they want that, and that's why we want it. Right? And the same with providers and so forth. And the Puri study shows those providers will make the same amount of money, work in the same number of hours. But guess what? They won't be pushing paper, they'll actually be treating patients. Those 11 hours that they're spending on paperwork will now be patient care hours. They'll be paid less than the commercial insurers, but they'll have more hours of clinical work that's reimbursed, salaries maintained, except, and I will just make this allowance, the neurosurgeons who are paid about $500,000 a year, they're going to get a hit. So it goes. So then it's comprehensive. It's comprehensive coverage. All services requiring a medical professional will be fully covered. You go to the doctor of your choice. All those Medicare Advantage benefits, dental, vision are covered, pharmaceuticals, and mental health parity. Obviously, long-term care. Extraordinary addition to the Medicare Act of 2019 is the new provisions for an emphasis on in-home supportive services and in-home care. Some elected officials in Washington are very invested in the nursing home industry, another problem. And so this obviously challenges that. It's free at the point of service because $1 or $5 can be a barrier to care. Literally. And any notion that 9.5% of your income is affordable on premiums plus deductibles and copays, you got to be pretty out of touch to believe that. So free at point of service, no copays, no fees, no deductibles, and no premiums ever. There is not an employer plan that can match that. There are some that do come close, I will say that, because I've talked to some yearly professors who have very good plans like that. But it is a very small portion of the country, and certainly in terms of workers, it's virtually non-existent. We talked earlier, universal. Universal means everybody, meaning non-residents included. That is, non-citizens included as residents. So non-citizens are included because of the very simple principle that we really are in this together. And finally, a jobs initiative, because we have to take this very seriously. 2 million workers are potentially affected by this reform under, again, the Puri study. We have provisions. We have provisions for transitional spending, about 2% a year for the first 2 or 3 years. Pensions maintained, because these are actually, in the healthcare industry side, very well paid. On the hospital administration side, not so much. Preserve pensions, preserve income for a year, do job retraining, and also move those folks into the still claims processing function of the new system, because there is an administrative function. But we have to take that very seriously. We have to go to insurance centers like Hartford and make the case. This is better for the country, we're going to protect you, and you're going to be better off too, even if you're an insurance industry worker. So it's a jobs initiative and severance for those affected. So here we are. We've won the policy debate. We understand the connections between health and justice. And yet, we have been in this decades-long fight to get rid of this profit-driven industry. And yes, some of us have been fighting this for a long time, and we're not proud, frankly, because we haven't won. It's time to win. That's the difference. It's time to win. And so, often we confront this phrase. Have you ever heard this phrase? Yes, very good points you make, but really, the beauty of the present system is that it provides choice and competition and innovation. Well, the next time you hear that, grab your wallet, because that's how they justify Stephen Helmsley's $66 million. That's how they justify the farmer profits. It's actually the way that they use to justify the present system, when in fact there's no choice, very little competition, and the innovation is first funded by the government. And that's true. There are some counties, most counties in the country might have 2 insurance companies on the exchange, maybe. And in fact, it's unregulated. What they really mean when they say choice, competition, and innovation is just what I said earlier: unregulated prices. That's what they mean. That is simply a free market ideological term to describe we want to charge you whatever we want and stay out of our way. And if that means 71 million people, either uninsured or underinsured, that's just the price of doing business. And so this democratic, pragmatic solution is to throw more money at them through tax subsidies. That's the solution that they offer. And so only through mass action are we actually going to be unable to undermine their program. And unlike the administrative waste and fragmentation and inadequate provider reimbursement, these tax giveaways of the present system, Medicare for All really is a publicly financed and administrative system that is accountable, that is democratic, and that is transparent. And that's supposedly what our country values in a system, is those kinds of transparencies. But really it comes down to something very simple. And every time we hear about alternatives, we can apply this principle. People get the health care they need when they need it without any barriers to care. People get the health care they need when they need it without any barriers to care. So, that's the conversation we need to have. How does your plan eliminate all barriers to care? Oh no, some barriers are okay. Representative Yarmouth, chair of the Congressional Budget Committee, said, oh, this is just universal and free. He was outraged. He's from Kentucky. He was outraged. A big insurance center, but used to be Louisville, used to be a big single-payer supporter. Now he's chair of the Budget Committee, right? Not anymore. So it is, of course, precisely because this is a class-based demand on the question of no barriers to care that directly, it's not only class-based, but it directly addresses the particularities of the human condition in those, whether it's gender or race. And so it is extraordinarily powerful politically because it unifies on the basis of people's shared sense of insecurity and anxiety around being able to afford health care, and it goes directly to their own sense of what they need to get health care. Because health care is the public policy that most intimately affects our lives. And so it has to address the human conditions in all of its particularity, and only a system that puts provider judgment up front, that doesn't let insurance company bureaucrats tell you where to go. 200 million claims a year denied, according to NNU research. That was reaffirmed by the Kaiser Family Foundation just in the ACA plans. They found nearly, I think it was 30 million claims denied by insurers in the Affordable Care Act. Their model is to deny care. Centene, a huge insurance company within Medicaid, Medicaid has been substantially privatized, so there are private insurers covering Medicaid recipients with our tax dollars. Centene is one of those companies. The industry press was exulting over their billion-dollar quarter, billion-dollar in profits. But a remarkable thing happened with Centene. They made more money, but had fewer members. So maybe they're not selling healthcare. They're selling something else. Because in capitalism, don't you have more customers to make more money? How do you make more money when you have fewer customers? Because maybe you're selling something else. And what you're selling, of course, is coverage. But coverage isn't care. Access isn't care. Ask again the 41 million people who have insurance but couldn't use it. Or the majority of Americans who don't have $400 in the bank. How do you afford a $1,300 deductible? So coverage is not care. So the next time you hear universal coverage, you say, how does that eliminate the barriers to care? How does that guarantee health care? Oh, I have access to the Four Seasons. I can walk in the lobby, but I can't rent a room. I'm not sure that's the same thing. Now, the question is then, how do we go about winning? Because it precisely does have the potential to go beyond the partisan dynamic. But it takes mass action, and once again, we have a lot to learn from our teachers. Because the teachers have done something extraordinary in this country. They have organized on a collective basis and forced Republicans to do something they don't want to do. Doesn't happen very often. Right? We were West Virginia, they're going, oh, you're going to raise our healthcare costs by 5%. We haven't had a raise in, 10 years. They went out on strike, and that changed. Last week, they were going to privatize half the West Virginia education system. They went on strike, and the legislature said, oh, I guess we won't do that. In Arizona, I was in Arizona, I have friends in Arizona who are teachers. They were like, we can't believe it, but this isn't stopping. So and it wasn't just the mass action, it was a sophisticated communications, social media program. That's the model for our campaign. It's got to be that mass collective action that compels, we have to understand, we have to compel the Democrats to do something they don't want to do. And this labor insurgency is a key to it. Let's talk a little bit about the pressure campaign that we've initiated nationally, and that Deborah was talking about here in terms of Representative Neal. We've been trying to move Representative Neal on this issue for
3 decades.
30 years.
Yeah, as long as he's been in
As long as he's been in.
Has he been there that long?
Yes.
Okay. So, are we going to move Richie Neal?
No.
No. The only person who's going to move Richie Neal to actually do a hearing and move the bill is Nancy Pelosi. So what we have to ask ourselves is, who might, that we know in this area, have influence on the speaker? Could it be the chair of her Rules Committee?
Yeah.
Could it be Jim McGovern? I think it could be. I think unlike Richie Neal, I think that Representative McGovern represents a district that is hugely in favor of this reform and is prepared to move their representative to ensure that he actually doesn't just support the bill, but really moves it through Congress. Because guess who will be responsible if this bill goes to John Yarmuth in budget? John Yarmuth, who says he opposes it. John Yarmuth, who's a part of the strategy to say, this isn't a matter of the healthcare system cost, this is just a matter of what it costs the budget. When you just talk about the budget, it looks very different than if you talk about how it's cheaper overall. Because in the budget, it looks like a huge $3 trillion times 3, because 60% of the funding for healthcare is already public. But when you add the other 40% onto the federal budget, that looks like a big number. So the budget is a place to kill it, to undermine it. So if Jim McGovern is on the Rules Committee and refers it to budget, he is killing the bill. I don't think people in his district want him to kill the bill. No. I think that every city council, potentially school board, county body, would urge Representative McGovern to move the bill, to urge Speaker Pelosi to move the bill, because he is her representative. He is in her leadership group and is key to her legislative strategy. So unlike other members who would say, let me know what you want me to do, here is a member who could say to her, my constituents will not let me off the hook on this. I cannot be responsible for killing this bill. Because a referral to budget kills this bill. And so I think we ought to make sure that there's a speak out in Richie Neal's district. I think we need to make sure that he knows we're never going away. But I also think that Representative McGovern needs to know that just sponsoring that bill, co-sponsoring that bill, is not enough. And we expect him to be a champion for this issue. We expect him to champion this with the Democratic leadership. We expect him to champion this so that this becomes the caucus position, just like it's the Democratic members' position. And we expect him to never give up as an advocate and champion and proponent of this. That, I think, is a strategic approach to how we move this Congress. But let's be real. We need a number of things. We need mass organizations like we're building here, like MassCare. The reason that the single-payer movement in Massachusetts is sustained is because it has a mass organization that is there and doing the work. Without organization, there is no movement. And I know sometimes I'm going to try to stop stepping on this as I've already destroyed it. We need to understand something about leadership. There's skepticism about leadership because it seems to be an imposition of power. But that's not really what leadership does. Leadership provides strategic direction to organization. We need that strategic direction at all levels. We need it in our chapters. We need it in our union locals. We need it on the Rules Committee in Congress. We need strategic leadership by Representative McGovern to move this issue. And we need strategic leadership at the presidential level. Because there is only one candidate running for president who will actually enact Medicare for all. And I don't give a damn what the rest of them say, they're not going to do it. Because they're going to the fundraisers of the people who benefit from the industry. They are hearing, you cannot be taken seriously as a pundit in Washington, D.C. if you think Medicare for all is viable and worth doing. It's one of those things in Washington that becomes the conventional wisdom. You must be skeptical of single payer to be legitimate. And so only mass movement and strategic leadership will be able to pierce that bubble. And so at the presidential level, you had, and Senator Sanders said it yesterday in Brooklyn. I mean, if you heard his section on Medicare for all, and you compare that to what anybody else says who's running for president, you're like, yeah, he means it. He means it. I don't know if she means it, I don't know if he means it, but Bernie means it. And that's the difference. That is the difference right there. And so DSA is part of this national fight. We've been going door to door. The canvases are essential because these conversations, it's unbelievable, these conversations. It's like, oh yeah, I'm a Republican, I'm an NRA member, and by God, I want Medicare for all. It's great. I mean, you can't get people to stop talking about it, basically, right? That's the thing. So we have to do that. The speak outs, we need to do we have to demonstrate on a mass basis. See, this is the thing, we've got to scale up our efforts. And we've got to demonstrate, I mean, Representative McGovern has an office on a pretty narrow street, I noticed, coming into Northampton. A busy, narrow street, I noticed. So that suggests possible tactics. We need to start thinking these ways, right?
It's down the Bay Bridge.
Well, it's been done. It's been done. Well, at least through Occupy and the port, it was done in 2011. So we had the pressure week. We had the National Week of Action, right? 9th through 14th. We're continuing that. And so some folks ask, well, why are you pushing for a floor vote this year? And here's the problem we have in this whole debate of confusion and alternatives and obfuscation and the whole thing, is that there's no defining moment, right? Because Richie Neal can say, oh, I support Medicare for all, but I want the conversation at state level, right? So then you say, okay, he supports it, now what do I do, right? Or, hey, I've signed on to the bill, so I'm good, right? But it hasn't done anything, ultimately. So that's why we need a floor vote, because we don't actually know which side they're on. We don't. We don't really know where they stand unless they vote. And that's what they say. I'm here to legislate. I'm here to vote. Well, then, goddamn it, take a vote. That's what I say. And until you take that vote, you do not know which side you're on. And so this is the other point. Aren't we a little tired of being on the defensive? Are we a little tired of having to respond to things like Speaker Pelosi saying we can't afford it? Well, how about Stephen Helmsley justifies $66 million in salary while you're denying millions of claims for people's care? Justify $12 billion in profits from a reform, right, that has left 29 million uninsured. Justify that. Justify why you won't have a floor vote on Medicare for all. Justify why it'll refer to a committee that will kill it. Justify defending the insurance company. Okay, Medicare for some. We'll have some people in Medicare and we'll preserve the private insurance for the employer plans. That's another idea. Okay, who are you leaving behind and why? Why are you subjecting them to a $1,300 deductible? Why are they going without care because they can't afford it? Make them defend the present system. Make them defend the insurance companies. Which side are you on? That's the moment we're in. And then if we can make this, we've already made it a decisive issue in 2020. They just want to muddy the water so much that it loses its power. We've got to make sure it doesn't, because we keep our eye on the insurers and what they're doing, and the pharmaceutical companies, what they're doing. So we need, it is literally at all levels. So this is not an electoral campaign. This is not a legislative campaign. This is not a community organizing campaign. This is not a communications campaign. It's all of that. It's all of that. It's not just one. And that's what we have to keep in mind. So the legislative tactic is essential. The canvassing is essential, but it has to be part of this broader movement and a strategic approach. So yes, run actions against insurance company shareholders. Take the fight to them. Put them on the defensive. If folks don't want to engage in electoral politics by electing the president who will actually deliver single payer, then go after the pharmaceutical companies. Demand that these hospitals not just try to solve the social problems that cause life expectancy. Life expectancy has gone down in this country. For the first time in the history of an industrialized country, life expectancy has gone down primarily because of the disease of despair in our communities. That the opioid crisis, suicide, particularly among men my age actually, has been a big reason for that decline in life expectancy. How can we justify that when people die because they can't afford their insulin? So yes, we have been at this for a while. John Dingell, whose widow is a co-chair of the Medicare for All caucus, introduced this bill with others in the 1940s. Ronald Reagan killed it, right, with the American Medical Association. We were on the verge of having a real fight for single-payer Medicare for All in '93, but the AFL-CIO decided to support Hillary Care instead. President Obama in 2009 knew that single-payer was the only way to cover everybody, but he learned the wrong lessons from the Hillary Care fight and decided not to take on the healthcare industry. So this, yes, we have a rising tide of support, but remember those lessons and how fleeting this can be. How fleeting this can be. We know the solution. We know 85% of Democrats support guaranteeing health care. So it has to be a litmus test in 2020. We have to say to the candidates, to Senator Klobuchar, if you're a pragmatist, why aren't you solving the problem? If you are committed, Senator Harris, to Medicare for All, then stick to it, right? Because even if we don't win at the federal level, we want to have a shovel-ready single-payer plan in Massachusetts, in New York, in California, so another Democrat would approve those waivers and let us prove at the state level the single-payer work. So we have to understand the state work as an integral part of the political strategy to demonstrate support for the demand. The state rep in Jim McGovern's district is the sponsor of the state bill, right, for single-payer. That tells us something about this district. That tells us something about the strategy we have to pursue and link them politically. And so we are really, we're using a process that we believe is legitimate in California to set up a council to iron out some of the issues that have arisen in this fight on a policy level. So we will have a shovel-ready program for a Democratic administration. Similarly, in New York, we can do that. And I think we could do it in Massachusetts, if not through enactment, at least in terms of a proposal, regardless of the governor. So when we understand just how fleeting this could be, and we see all the opposition rising, the bipartisan opposition. I mean, there's a claim that even the president wrote an op-ed, right? And he used that opportunity to go after us last fall in USA Today. In a State of the Union speech, it seems like he was quite obsessed, one might say, right? So this, and then you see all this stuff from Speaker Pelosi or John Cronin, and you realize the simple fact, and that is we're winning. We're winning. Because they can't defeat Medicare for All, so they have to do all these things to try to undermine it. And truly is a sign that elites are actually worried we might abolish the private insurance. And you saw the reaction with Senator Harris. Oh, hold it, Senator Harris. You weren't supposed to be a Bernie Sanders radical, but you still want to eliminate the private insurance industry? To her credit, she didn't back down that far. But what's amazing is how outraged the commentators were. Oh my God, the private insurance. And so this is really our moment. This is really our time. It's a downright murderous industry that's indefensible. That if we don't succeed, more people will die. Our lack of success has killed tens of thousands of people in this country. It is literally a matter of life and death. And so our movement must be a movement to save lives and be explicit about it. Who are you killing by keeping them out of Medicare for all? Who are you killing by keeping them in a system where 42% of cancer patients go bankrupt within 2 years? Why is that okay? Make them defend that. And they are prepared to defend it, and so we have to combat it with this mass movement of working class people. It is a matter of life and death. And of course, we're animated by what Dr. King says. Of all forms of inequality or injustice in healthcare is the most shocking and inhumane. And our struggle for health justice can help us reclaim our humanity, the human kindness at the heart of solidarity. As we reject the corruption, and it is truly corrupt at the present moment, we can envision and articulate an equitable society where working people make the decisions that determine our lives, and that's why it's such a profound threat. And if we do that, if we win this fight, we can change the ethos, and we can actually go after the political economic structures which got us here and which inhibit our future freedom. Because without health, how can we be free? And that's why we say nothing less. Thank you.
So we've got some time for question and answer for both of our speakers. When you signed in, you should have been given a scrap piece of paper that you could write your question on. However, because we're such a small group, maybe we'll just take hands and I'll facilitate the Q&A that way. So yeah, Deborah and Michael, if you guys would join us up here. Out of the way. Okay. Questions for Deborah and or Michael? Yes.
So I'm not sure who these are for, so if I could just ask, and I wrote down a couple of questions, and I suspect they're more for Michael, but, you know, you guys can arm wrestle. So you mentioned something, I mean, you know, this huge barrage of data we all get back. You mentioned something that I don't know what they are. You mentioned a term called charge masters.
Oh, yeah, right,
And
that was that. I
don't know what
wonky.
that means.
I got wonky. Sorry.
That's
my Andy
no,
Beckett joke. That's like, you know, we can't help ourselves, right? Essentially hospitals, and there are actually some new legislation but they have to do this anyway. They have to keep track of what they charge for every given procedure or treatment that occurs in the hospital. And so they have literally a master list of prices, right? Which are charges. Those charges are much greater than their actual costs for providing that treatment. But they do that intentionally so that they can increase the reimbursement from insurance companies in particular. How hospitals actually get paid by Medicare is based upon what's called a diagnostic-related group. So you actually don't pay for individual treatments and procedures in hospitals, you pay for the overall episode of care based on the DRG that's assigned to it, right? So the masters may reflect that as well. But that is their charge for that care, not, of course, the cost necessarily, or what they get reimbursed from Medicare. So the charge master is essentially their price list.
And are other people, are citizens allowed to see it?
Well, California passed this transparency law,
Yeah.
right? And the idea was, oh, this will be great because we'll be able to shop. Next time I have a heart attack, I can say, oh yeah, pull out my charge masters and review them. But so the answer is actually, ironically, yes. And so Sutter Health, which is an notoriously anti-union corporation. They published kind of like their literal charge master, which is just gobbledygook. I mean, you literally, it's like a computer printout of these codes and numbers that is indecipherable. So, yes.
Other questions?
I have two different questions. One is specific and one is general. My specific question is, I personally am here because I already agree with you in everything that you say. I happen to have worked in healthcare admin for decades. I know it from the inside, and I already agree with you. How will you address the anxieties of a person who's been working in the healthcare industry, who's, let's say, 51 years old, so they're too young to be able to afford to retire with a severance package, but too old in this economy to have a very good chance to compete with younger people if you're trying to move them into a new job. Okay, that's my specific question. My general question is, it was very helpful that you used the teachers' strike as an example of what effective political action looks like. But what you are talking about is such a fundamental change in American identity and ethos, I am sorry to say, in terms of people who are under duress, caring about the common good, when they're feeling like the rug's been pulled out under them, all these things that happened in the most recent presidential campaign. My general question is, can you point to a movement in American history where there has been a change in attitude that is as widespread as what you are saying needs to happen for this to happen?
Well, that's a good one. So, a couple things. One is, I do somewhat reject the premise that this is a radical transformation, because Medicare exists. It was originally a single payer. Other countries do it. And we've quantified pretty precisely how much less it will cost. And 60% of the money to pay for healthcare already comes from taxes. So we're basically reducing the overall cost, replacing the premiums, co-pays, and deductibles that you pay now with an increase in tax, which will be much less than what you're paying now.
I agree.
So I'm just saying, so that is not a hugely radical change. But I do agree that I was making the case that the ethos and the vision behind it and what it represents in terms of social solidarity and the threat to class interests is a radical challenge. So it is true for both. It's politically radical in the sense that it's a systemic challenge, but if you look at the things that Bernie talked about yesterday in Brooklyn, it's of a piece with College for All. It's of a piece with the Fight for 15. And that's my second point. We're not going to win this on its own. If the minimum wage stays at $7.25, we're not going to have guaranteed health care. It is part of the rising justice movement that this will happen. And the answer to thirdly is the civil rights movement. Because 400 years the Southern plantation class controlled labor relations in this country, first through slavery, then through Jim Crow after Reconstruction. And it was only until the civil rights movement that their stranglehold on the South and labor relations in general was broken by the civil rights movement. And that took 20 years after World War II, because those soldiers came back, and that really animated the civil rights movement, that discrepancy between Jim Crow and giving your life for this country. So Medicare desegregated American hospitals in 1965. Medicare ended the remnants of Jim Crow in hospitals. African American people died because they were in basements of hospitals, because they died on the way to the colored hospital. Just like people are dying now because they're black or Puerto Rican or poor. And we changed it then, and we can change it now.
Can you answer the question about healthcare industry workers,
Oh,
maybe in their 50s?
There's actually, just to say, sorry, but in the Peary study, we have a very specific plan for that transition, and precisely for those workers. So what happens essentially, if you are in that space, we're not going to expect to train those folks for clinical jobs. We would like to train younger workers for clinical jobs. There are lots of administrative work to be done in the new system. Because, yes, there's less. Medicare costs 3%, private insurance costs 12%. The difference are jobs, but you still got to pay providers. You still got to process claims. So the folks who get first shot at those jobs are ones who are doing that work now, who haven't otherwise retired or retrained. Now, are there enough jobs for those folks in their 50s? Chances are yes, there probably are. For the group of people who are not going to retire and are too old to be retrained, that's the sweet spot for those jobs that are the same in the new system as the old. Not underwriting and denial, but seeing a claim, paying it. So that's where we think those kind of workers go. That's, of course, not necessarily, that's right, it needs to be detailed, and it needs to be, that's why I'm arguing for a very precise and specific transition program for those workers. The Jayapal Medicare House Bill, Medicare for All House Bill, has a 2-year transition. Senator Sanders had 4. We believe it should be 1. That's how long it took Medicare, because the one way to convince people this is a better system is to give it to them fast. And that will help the worker transition. That will also help the worker transition, because we're going to need those people to start processing claims right away. We're going to have to generate the money to maintain income, because remember, we have an income maintenance for a year. Right, and that's a good, landing, or takeoff point for their new, hopefully, their new job.
All right, I saw Willie in the back, and then I know there's a few hands over here.
On the state level, and this is for Deborah or Michael, you said we want to kind of get ready for shovel-ready, some shovel-ready state, something or other, in 2021 when the federal government might do something. So can you, I maybe missed it, or can you kind of lay out how that state, what we can do to prepare for, say, the upcoming Bernie Sanders presidency?
I don't know, it'd be fun. We do have legislation that's been submitted over the past 20 years. It's evolved somewhat, but it's a good, solid, single-payer piece of legislation that could be shovel-ready, I would say. Actually, I don't think it's shovel-ready yet. I think it's a good start. I think the work that we do over the next 2 years with the legislative caucus is going to be really important. The kind of studies that we do, and especially impact studies, I think the cost analysis is just going to show what every cost analysis always shows. But the impact studies, perhaps a little bit more focused on how is this going to impact providers, how is it going to impact displaced workers, that type of thing, will be really important and will help make it shovel-ready.
The other specific thing I was saying, Willie, because see, this is exactly right. I mean, you have, in California, we've got this council, and we're going to do the same work in terms of impact and financing and policy development, service delivery in particular. And so the idea is that then becomes the framework for writing the waiver requests to Health and Human Services to approve. Because there's actually, there's very clear analysis, because I helped write the California bill, so we were dealing with these issues, that you can actually get waivers. Even you can have states administer Medicare, you can organize ways around some of the ERISA issues, you can get a Medicaid, you can set up a Medicaid waiver to pool those funds, you can get the Children's Health Insurance Program funds and pool those. So what you want to do essentially is create a single pipe. So for all the revenues that come into healthcare, it goes into one pipe, no matter where it comes from originally, and then pays providers. That's the single payer, right, is that pot. And so what you need from the federal government to do it in Massachusetts are certain waivers, some of which, like ERISA, you can't just waive, and we don't need those as a single payer that would help. Others you can just waive administratively, 1332 under the ACA Act, 1115 under Social Security Act. So you could, in Massachusetts, have an informal process that would do that because the governor isn't going to sign off on it. In California, the governor is signing off on it. That's what I mean by shovel ready. Here's our waiver, give us single payer in Massachusetts. Here's our waiver request, grant it, we'll have single payer. That makes sense.
I saw Joe.
So I just had a question, is that Perry study available online?
Yeah, Peary.edu gets your home, Peary.umass.edu. PERI.umass.edu gets you to their homepage, and you'll see it. Scroll down, economic analysis of Medicare for all.
I just Googled UMass Medicare for all, and it came right up.
Oh, yeah. So I do have a question though. You said we're winning. I heard that before. It's like we're winning. But seriously, we went through the brutal campaign on question 1. Corporate money and corporate lies beat the hell out of us. Killed us. Despite, we had like 80% approval going into it, and got killed. So if we're, seriously, if this, the corporate money is going to come killing us, and I worry about that. So it's more of a comment. I just...
Well, no, you're right to be worried. I mean, if the healthcare industry, broadly defined, spent 1/10 of their revenue, they'd have about $100 billion to fight us. So yeah, they're rich and powerful, right? That's why sometimes the initiative process is too susceptible to that kind of deep pocket money. That's why you have to elect a president who won't give up. I mean, that really is why. Because the thing is, if you have a mass movement and a president, then there are people in between those two forces that aren't usually in that position. Because usually the president's on their side, right? Or the legislature's on their side. So you have to change the equation by having two powerful elements in play. What we've learned is we've never had a president committed to this. Since FDR, even Truman wasn't that committed, right? So and I'm not saying that's a panacea. I'm not saying it's sufficient. I'm just saying it's necessary. Every time I confronted labor political directors in Washington, D.C., they would tell me, if the president doesn't want to do it, labor can't do it. For the first time, we, NNU, took on President Obama in 2011 over the financial crisis. For the first time, unions have protested the administration financial policies. We were out in front of Treasury. So it doesn't happen. That's the difference. You listen to Senator Sanders yesterday, and you don't get that from anybody else. And I'm not saying, that no one else isn't committed to trying to improve people's health, right? But there's a difference. And that difference is why we could win this time.
There was one other hand that was up over here.
I actually have a question in the queue.
Okay, so I'll take you, and then Pat, you'll be after.
I think it's really interesting, the yellow
Vest.
hood,
Vest.
coats,
Yeah,
yellow
yeah,
vests.
yeah.
Yeah, it's so interesting that they kept on coming, and it was during the winter too. It was cold, and they kept on coming, and there was talk of them being, infiltrated by bad guys. But they kept on coming. It was quite, and they were coming from far away too. It wasn't like they were in Paris. And I realized that's them. It's not necessarily us, but they're definitely people to watch. I mean, it's a spirit of determination.
It's a lesson.
And it also went from huge numbers to very cold days after a month of winter where it was like 100 people. But it was still, they kept at it. And he listened to them. I mean, who knows whether anything got done. But the French big guys were scared.
It's often said that the French government, that Americans fear their government, and the French government fears the French people.
As they should.
And that's what we need to change.
Patrick.
I'm just a little curious about, I'm not as familiar with the work, state level work in New York and California, but I'm a labor council president for Hampshire Franklin, so it covers curious about how, I know that there are parts of the labor movement that are not going to be for single payer, but like what parts of the labor movement were you able, like at least in California, maybe we have more direct experience, we're able to pull into the orbit and become more, strong allies.
Well, I think the main state labor federations do the best worker education program on single payer. And they're able to talk, I've been in rooms with IBEW members, have very good conversations that get a lot of support. So I would go, I think there's a whole rank and file worker education program, and so in Maine, they moved from a kind of worker education program to an outright campaign to generate support for Medicare for All among unions, and got a lot of buy-in through a somewhat extended process among all their state fed board members, right? So I think that is a model, right? Secondly, what we found, like you take Unite Here, for example, right? Unite Here is an organizing union. Are you from Unite Here?
No. I am.
Oh, you are, yeah, exactly. You know, Francis.
I know.
You can't, these hospitals, they compare what they pay under the union contract for healthcare, what they pay now, and they're like, boycott me from here until eternity. It will never cost me as much. Right?
Yes, that is true.
But I mean, so this is, right, because it's just so expensive. Healthcare now is so expensive. In San Francisco, they pay more per hour for healthcare than I think they earn in wages in some classifications.
Yes.
Right?
Yes.
So hotel workers have been a huge part of our campaign in California. The building trades leader, who's Irish, supports single payer. The difference is labor is not going to take, in our experience in California, labor is not going to take on the Democrats. So we got in a fight with the Speaker of the Assembly, a notorious fight with the Speaker of the Assembly. We lost all of our labor support because he's their guy, right? So this is the political dynamic that we have to navigate, because we have to, that's why you always have to kind of ratchet the pressure up on Democrats so they don't become a barrier to maybe some of the organizations that are linked, right, politically to them. So that's part of the give and take. But we found success with the building trades, success with IBEW. I mean, John Walsh here from Massachusetts has been very involved. He's been down in DC for a long time. So I still think there's a lot of potential there, and that's what I saw in Maine as well. Certified school employees, I don't know who's represented in here. Is SEIU, or they have their own union?
I don't know who that is.
The non-teachers. The non-teachers.
It is SEIU.
Yeah, the non-teachers in education. Very strong supporters in California. AFT is now on Medicare for All Act in a big way. President of AFT spoke. The teachers are on fire, obviously. I think actually AFT, potentially NEA, but definitely AFT is now a new element in our movement. I think they're coming to the fore, and I think actually this is the truth. There's the people who have the most at stake in healthcare are actually students, teachers, and parents in the healthcare fight. We estimated in Florida, you go to single payer in Florida, the school districts would save $700 million. You want to fund schools, go to single payer. Like, okay, people want to pay more taxes for education, well then pay less for healthcare and pay more for education, because we know in the state budget, if you got more money, you're going to give it to education. So it's a great issue for all the education unions. And then the machinists are newly engaged. They were big, I don't know how big they are here on the issue, but they were big in DC last week for the bill introduction. So the machinists have stepped up, and one of their political affiliations is a union I'm working with in California, who represents mental health care workers, and they are now the machinists are now playing more in the labor campaign for single payer. So that's a whole new thing.
Bernie had the president of UE.
Well, Peter, no.
No, I'm talking about here in PA on strike now.
Oh, yes, right, exactly.
Had the president of that local there speak.
Yeah, the president of the Erie local, which is on strike, UE Erie local, which is like a bedrock local in that union. It's like a big, big deal. Spoke with Bernie. Was it Brooklyn or where was it?
It was in
Yeah,
Brooklyn.
yesterday.
The speakers at the rally.
Yeah, he was one of the pre-speakers. Yeah. So of course the UE obviously is involved as well. So do you think of anyone else?
Yeah, Deborah has a question actually.
So about the teacher strikes, because they're revolutionary, I think, what's going on. But they're striking. You know, that is a movement that is based on power and strike. And while health insurance has been an issue for in several of those states where it's been going on. It has not come forward as part of the spoken agenda in any clear way. And I'm wondering, and at the national level, are there conversations going on with, are there conversations going on with the teachers about that? Why or why not hasn't this arisen to a more visible part of the agenda?
Well, the NEA is the largest teacher organization in the country, and they are both kind of professionally oriented as opposed to union oriented historically, and they're very tight with the Democratic Party. So the NEA is not going to get ahead of the Democratic Party, I don't think, on a big national policy issue. That's going to be a tough dynamic, I think.
The strikes are not necessarily coming from the NEA.
Which was my point, exactly. Which is where I was going.
Okay.
This is not going to be decided by the labor leadership in D.C.
That's right.
Okay? They are part of some aspects of this system that are a barrier to us. And I'm not critical of them because they have given blood, sweat, and tears to win labor contracts, and they've been dealt this hand since the 1940s, and they're going to make the best of it. So I get that. However, they don't want to be part of this no Medicare for all effort because their members, by and large, support it. And that's where it goes. That's where I'm going, is that you have to have a rank and file strategy. So yeah, maybe we're not going to take the workers out on strike necessarily over health care, but that's going to happen anyway. In most cases, every collective bargaining fight's about healthcare, right? So what we have to do is we have to escalate just what you said, the communication. We have to make sure everyone knows this is a healthcare fight. Even the Marriott strikes were ultimately about healthcare, right? So really, this is at the root of every worker's struggle, and we just have to publicize that. And the mass action that we have to take, the teachers will join. Maybe we're not going to take them out on Friday, but let's all get together on Saturday. I was in Arizona with the teachers and nurses. Whoa! These newly organized nurses and these teachers who have been striking Red for Ed, look out. That's all I'm saying, is that we get these folks together in terms of rallies, speak outs, town halls, mass actions, say in front of Jim McGovern's office. These things can matter.
So we have time for, let's say, 2 more questions. So, okay, I see 3 hands, so we'll go 3, but we'll start with someone who hasn't asked yet. So Joe.
So, I'm a small business owner, retail. And, trying to get, it's a lower wage business. And, trying to get everybody up to $15 an hour is the goal right now, which we're not there yet, but hopefully in a few years. But then adding on a cost of health insurance, which is in the state bill, right? I think it's going to be hard to get small business people behind this, and the margins are not there. So I just wanted to bring that up, and if there's any strategies or tactics that people have been working with people. I have an independent bookstore, so it's more progressive business, and my colleagues are more progressive around New England, but still I think it's going to be hard for people to get behind it.
Right, that's why our financing plan exempts small business. Under our plan, small businesses don't pay anything. Right. And that's you look at the Peary study, that's what we do. So that's what you have to do. I mean, basically, what's really extraordinary is that businesses, who do, in your situation, have the margin to pay for insurance, spend about 22% of payroll on it. And this will reduce it to 0. For them, and for those not providing it because they can't afford it, they will be exempted, at certain levels. And so the issue is going to be what's the revenue level, what's the payroll, size that gets that exemption.
Well, I can see it that it would help with turnover tremendously, because in my situation, as soon as somebody gets married or has a baby, they're not going to stay.
Well, that's a very interesting point, Joe, because it's like reverse job lock. We talk about the folks who are stuck in jobs because they have insurance. What about the people who can't stay in a job because they don't?
So why is it in the state bill?
It's a good question.
It's hard. I'll tell you, we can fix that too, because in California we had a bill that did the same thing. But it's hard to do. It's harder to do at the state level.
My feeling is that the state bill should have a financing plan with graduated exemptions for employees as well as for businesses. It's been controversial and it hasn't been sorted out yet, but I think we need to go in that direction.
Okay, so I saw one hand there, and then we'll end with you right there.
I think so. This isn't like a fully formed question, but I was wondering, whether you could be a little more like the risks to the movement, sort of like, I guess you spoke a lot about sort of why this is inevitable, why it's, or not why it's inevitable, why it should happen. I'm wondering if we could speak a little bit to like, how do we lose? You know, like what are the vulnerabilities of the movement, and what do we need to look out for? There's sort of like, and it's not just they have more money.
No.
Like what are they going to utilize?
No, really, this is a very important question because it goes back to Patrick about labor. Labor is really at the fulcrum of the answer to that because union members have really fought for these health plans. And what the Democratic senators are saying is you got to somehow convince me that getting rid of these employer plans isn't going to kill me politically. And they're not really necessarily talking about their voters. They're kind of talking about their institutional base or their donor base or their organizational base. And this is their constituency, the labor movement. And the labor movement's coming to me and telling me this isn't good for us. Right? That's a problem, and that's our biggest problem, frankly. Senators, members of the House that I talk to don't believe financing is actually a problem. They think that the tax cut bill for the Republicans blew up in their face so badly that we can tax the rich and we can make an argument for taxing the rich to win Medicare for all. They think really the problem is this, and I had it with this Texas state rep I was talking to. The first thing he says is, John Cronin's going around saying we're going to be prepared to lose your employer-sponsored health care. What do I say to that? I'm saying, so this is a Democrat. He's like, I'm a hardcore Democrat. And we're not making people give up their employer plans if they like them, are we? So this is where we're at, right? And I don't think if you talk to workers, that's true.
What, do they want to keep?
They want to keep. I mean, even I hear workers who are literally just giving everything, right, for their health plans. I think they would say, I maybe don't want to keep giving that.
We would absolutely much rather have Medicare for all. Yeah.
So I would hear that from workers, right? And there's a huge level of investment in trust funds and so forth. So I think that if our movement gets derailed, it will be because people who have it, right, who have good plans, are too afraid. And I don't blame them. I mean, it's a desperate world out there. And so you got to hold on to what you have. And if you're not convinced this is actually going to happen or be better, I'll just stick it out, right? That's what we got to do.
Yeah, I don't know if you wanted to take that question to the state level about like kind of what our vulnerabilities are, what are, because I'm asking Deborah this because I know like we at the state level we talk about this, especially what we can take away from the loss on question 1 and what kind of opposition we would be facing here in Massachusetts. And my feeling is the opposition we'd be facing against our single payer system is just what they saw on question 1, that was a drop in the bucket to what we will be looking at to radically transform the system. So I think that we do have to start thinking about where our vulnerabilities are and planning for that in advance and doing research on who our opposition is. And that's not easy. I mean, they're incredibly organized, right? The hospitals, the pharmaceuticals, the insurance companies, they're incredibly organized together to oppose us. So the first step is we need to be highly organized as well. And then know who they are and try to know our vulnerabilities and try to find out what their vulnerabilities are too.
Let me just one quick point on the difference between question 1 and this.
Yeah.
Unfortunately, the hospitals enjoy a better reputation than they deserve.
Yes. Yes.
And so, it's harder to vilify them. The insurance companies do not enjoy that.
Right.
That is a big difference. It's very easy for people to hate their insurance companies. It's harder for them to hate their hospital.
Mm-hmm. And the problem in Massachusetts is a lot of hospitals will not be with us on this. Partners is not going to.
Oh, I guarantee you.
Partners is not going to love single payer, and people love partners.
But what is it? Is it the Boston Medical Center? Do I have that name right? It's basically it's mostly funded by Medicaid. the administrator was at this panel and she said, well, 80% of my money's from Medicaid and Medicare, but we don't want single payer.
Then we can get Mass General, we may be able to split the hospital.
That's exactly right. You split the hospitals, you vilify the insurers, and then you go after pharma. It's very different from question one in that sense.
Yeah, that's a good point. And then I'm gonna invoke my privilege, because I'm standing up here, to make another point on labor, and then I'll let you have your final question. As a negotiator, as a labor negotiator, just to Michael's point about how even union members, in my belief also, would be willing to give up these employer-sponsored plans. Every time we're at the bargaining table, it is literally, is it wages or is it your health care? And it doesn't matter what pocket you choose, both of those pockets belong to the workers, because the boss is essentially saying, costs are rising on this one hand, and I'm shoving that off onto you for your health insurance. I'm changing the plan so that your deductible goes up, but the premiums are never decreasing. They're always increasing, no matter how crappy the plan design is. And then the wages, they always use health insurance as an excuse for why they cannot pay larger wage increases. So union members are fed up with that argument, and they're ready to take health insurance out of the equation. So, yeah.
So
Final question.
we talked about Richie Neal. So a week ago, we had a Congressional District 1 town meeting in this room. We invited Richie Neal. And he didn't come, and we had a big poster of Richie Neal that we all spoke to. And we spoke to him about two issues, and one was the Green New Deal, and the other was getting Trump's taxes. And in the last week, what has happened? He's going for Trump's taxes. So call Richie Neal and try to convince him that this is important. And I'm not going to assume Richie Neal's not movable. I mean, this is a big movement that he just made on taxes. So that you've been kind of answering my questions, but this difference between the federal approach and the state approach, and I talked to lots of people who believe that the only way to do this is to have a bunch of states like California and Massachusetts and New York adopt these plans first, and then it'll spread. And yet, doing it at the state level just feels like it's got a lot of barriers, like what to do about Medicare and whether Massachusetts can attack the pharmaceutical pricing stuff, whereas those things all seem rolled into the federal plan. So I don't know. I just don't know how to weigh those two things.
This is a political fight. It's not a policy fight. It's not about what single-payer version of the state, or it's about, do working class people have the political power to make these people guarantee us health care with no barriers to care? So that's true for the state rep here is on that side. Super government says he's on that side. Rich Neal's not on that side. He's not. Rich Neal's going after his taxes because it works politically for him, because the speaker said it worked politically.
Rich Neal gets more of his money from PACs than any other rep in Congress. And
because that's what the Ways and Means Committee is designed to do. That's why it exists.
And the pharmaceutical
What does Congress do? Congress will do nothing except one thing every year: appropriate money. And who gets the money is what lobbying is about. That is what Congress is. So yeah, that's what Ways and Means is. That's what they do. That's what every Democratic president has done since FDR, essentially. And that's why it has to be different at all levels. And that's why the political fight has to be taken to all levels on that basis, right? And so I'm kind of energized by Bernie's speech yesterday. I mean, it's just, we got to take it. We got to make it simple and direct on these questions and have no equivocation. So, will you guarantee me health care with no barriers to care, Representative Neal, or will you keep taking money from Partners and United Health and Centene and every healthcare industry PAC in the world so we don't get what we need? And this has to be stark.
And he'll just say, I support the ACA and I support access to health.
Exactly, and say, but that doesn't guarantee me health care. Right, yeah. And so, I mean, that's why, again, I say Representative McGovern, who agrees with us,
needs to be a strategic leader for us.
And I think he will, because he did say to a bunch of us that he was going to make sure that Medicare for All got a hearing on the House floor. He did
That
say
is
that.
BS.
Yeah.
Because that means he can refer to budget,
Well,
where the chairman
he
of...
said the floor,
No,
he
no.
didn't say the committee.
A hearing on the floor. There is no hearing on the floor. There are hearings in committee and there are votes on the floor. There are hearings in committee and there are votes on the floor. So if he commits to a vote on the floor, that would be real. If he commits to a hearing, that's a committee. If it's the budget, he's killed the bill.
So what committee does it go to?
It needs to go to Ways and Means or Energy and Commerce, because then you can talk about the whole system. In budget, you talk about the Medicare budget, the federal budget, the Medicaid budget. How is this? So you're talking about tens of trillions of dollars over 10 years that looks like, whoa, how do we afford that, says Speaker Pelosi. The Budget Committee is designed to buttress her argument.
Green New Deal over exactly the same argument. How do we afford it?
No, yes, of course, but then in Ways and Means we can say, because you won't be paying any more insurance company premiums or deductibles, and then they'll say in budget, well, that doesn't impact the federal budget. But at Ways and Means, they say, oh, well, yeah, that means that affects the tax rate, right? Every subsidy that they give employers, every subsidy for providing health insurance is a tax expenditure. That's why it's in Ways, obviously, it's why it's in Ways and Means.
In Massachusetts, there's an organization called the MMA. They represent all of the towns. And they're being beat up by the towns who are all going broke. And a lot of it is their health care costs. And the MMA is taking a serious look at single payer as a way to lower their health care costs. And they need to be pushed into doing a good study. And they're not partisan. They have Governor Baker's ear. You know, they're highly respected.
What makes you think they're taking a close look? I'm just curious.
Because they tell me that.
Who are you?
I'm a selectman in Conway, and I go to a lot of the selectmen's meetings. I just get to talk to the MMA.
Yeah, you guys should connect them.
Sorry, I didn't mean
I think that's where it's going to happen, Joe. I think it's exactly that way. Municipalities, school districts, states are going to... The retiree health liability for California is $80 billion.
Yeah.
Who's going to pay for that? Right?
All right, we'll take your quick
No, it's
one.
not a question. You were talking about the Commonwealth Fund and Ways and Means. The Commonwealth Fund actually did a segment with the Ways and Means last week. I listened to a lot of I read what was presented, and it's right in line with they didn't use Perry stuff, but all the issues are addressed in Bernie's and in the Perry study.
Oh, really?
Essentially, we're talking about it. I sent it out.
Yeah, no, I know you did, and I
I
have
think that's one thing, and that is important, Richie's, and no one stops, and no one should stop contacting Richie.
That's right. No one should stop contacting him. Absolutely, I totally agree with that. This Commonwealth Fund is a great resource because they're nonpartisan, and every study they put out basically proves our case.
What is it called? Sorry?
Commonwealth Fund. They do the international comparative work every 2 years. They do their mirror study, and every year the U.S. comes in 13th out of 13, and every year the most socialized system comes on top for equity and outcomes. That's the UK, and every year it's ignored.
Who are they?
They're a nonpartisan research institute in Boston.
All right.
Or Cambridge, maybe?
Oh, I don't know.
Yeah.
To me, it's all the same. Yeah. When you're out here in the west.
Oh yeah, sorry. Sorry, that's right. I don't have to make that distinction here.
So let's thank our speakers very much. And don't forget, we have tons of work to do. So you would have seen the number to call Richard Neal's office to pressure him, especially if you're a constituent of his, as I think a lot of us in the room are. Call through this number so that we can track it through National Nurses United. Also, looks like we're gonna have to have some conversations with Jim McGovern. Be looking out for updates through the Western Mass Medicare for All and the Mass Care and PVDSA lists. And we are canvassing in Holyoke, March
9th and 16th.
9th and 16th, meeting here at 11 a.m.
Apartment
Yep.
11-1.
And then a DSA-sponsored canvas on the 23rd and 30th at 2 p.m. on Main Street at a music and art school.
And this
So
is depression canvassing too?
this is canvassing to specifically to put pressure on Richard Neal. Yes, in support of Medicare for All. All right, thank you all for being here. Until next time. Thanks, Tom.
It was delightful. Thank you.